Hi, I'm Dr. Leslie Johnson of Emory University, and in this lecture, we'll be discussing implementation strategies. In Module 1, we spent time defining and differentiating between evidence-based interventions and implementation strategies. Now, in Module 5, we'll focus on designing and testing implementation strategies. By the end of this lecture, you will be able to discuss challenges in standardizing how we define and categorize implementation strategies, describe examples of implementation strategies using terms and definitions put forth as a part of the expert recommendations for implementing change study, and explain the factors that influence the selection or design of implementation strategies. In Module 1B, we covered how implementation strategies are interventions on the system to increase adoption of evidence-based interventions into usual practice. You might find it helpful to think about the evidence-based intervention as the what you are implementing and implementation strategies as the how you will accomplish that goal. When you look at the published literature and implementation science, one thing you'll likely note is there's significant variability into how researchers operationalize and apply and report implementation strategies. And this becomes even more complex when we start thinking about using multiple strategies. Take a moment and consider, what is the value in having a shared language for discussing implementation strategies? As a field, if we don't have a shared language, it becomes challenging to communicate what strategies we are testing or compare what we've done to researchers working in other settings and populations. To overcome this challenge, the expert recommendations for implementing change, or the ERIC study, as you'll often hear, referred to conduct a study, and they surveyed experts in the field to compile a list of these implementation strategies with definitions and guidance on when and how to use each strategy. Through conducting a modified Delphi process, the expert panel engaged on the initial study was able to reach consensus on 73 different implementation strategies. The full list with these definitions are provided as a supplementary material to the published study. An example of one such study, implementation strategy defined, included the strategy of altering incentive structures, which the authors define as work to incentivize the adoption and implementation of the clinical innovation. This definition is still broad, though, and could be better specified to understand what that means within the setting of interest. Are you giving clinics financial incentives when performance metrics at the clinic level around chronic disease care, for example, are met? Or are you rewarding individual clinicians for adopting the chronic care guideline of interest? Another example is creating new clinical teams. By stating this is your implementation strategy, it doesn't convey to those working in your space who is involved in the project and how it was operationalized. Perhaps you're interested in implementing a collaborative care model and you add a psychiatrist to your team. Or if you don't already have all the disciplines, or if you already have all the disciplines represented within your care team, perhaps you're trying to identify someone who has a different kind of skill set that's missing in your current team. It'll be important to identify the strategy, but even more so to define it within your research context in more specific details. Lastly, we have the example of changing record systems to allow better assessment of implementation or in clinical outcomes. The ERIC tool provides suggestions on what this might entail, say modifying the format of clinical notes to capture whether implementation even occurred. Let's consider this issue from a different perspective. Say you're reading up on how to best implement your evidence-based intervention. For example, integrating depression treatment into a diabetes care setting. And you come across two articles that provide the following descriptions. The first states that they used a decision support software linked to electronic medical records to prompt clinicians to treat depression. Second, provided a paper form with which the depression screening algorithm was present and indicated what scores necessitated treatment. Would you classify these as the same strategy? While they may take different forms, the purpose is the same, and I would consider these both to function as a strategy to remind clinicians. Both labels and descriptions are helpful as they allow for easier comparison across studies and enable us to see how strategies are tailored to meet the needs of certain settings and may be more or less appropriate for your own when you're thinking about adapting it yourself. As an added benefit, the better you specify your strategy, the easier it will be to think about how you will conduct monitoring and evaluation of those strategies. As you think about reporting your implementation strategies, you may find this reporting standard put forth by Proctor and colleagues to be helpful. It outlines several dimensions of your selected strategy to help you define what it entails. In brief, it includes identifying the actor that will be delivering an intervention, what actions need to be taken by that individual, what the targets of the implementation strategies are, the sequence of events that have to occur, the intensity of those events, and you need to ensure your strategies align with your targeted implementation outcome and that there's just cause for using the strategy. If we consider our previous example of the strategy reminding clinicians when implementing an integrated depression and diabetes treatment care model, we might define our strategy as follows. A nurse will screen patients for depression, input data into an electronic decision support system, and deliver depression treatment prompts to clinicians during those patient care encounters in order to increase clinicians' awareness of patients' mental health needs and increase their knowledge of depression treatment protocol. These sequenced events will occur at each patient visit to increase uptake of depression treatment guidelines in a diabetes care setting. The use of clinician reminders is warranted given that there's evidence of clinical inertia to perform these screeners. Each dimension adds specific details to help our researchers understand the implementation strategy and can even aid practitioners with implementation planning. As you consider these strategies and which may be most appropriate to use, you can also think about how they cluster together to serve different purposes. Building off of work completed in the ERIC study to compile that list of 73 implementation strategies, Waltz and colleagues then examined how they were conceptually distinct from one another. Ultimately, they found that there was 9 categories of strategies ranging from changing infrastructure to adapting and tailoring the context. You may wish to pause and consider which types of strategies address implementation barriers related to your no-do gap. I want to reiterate that last piece on justifying the selected strategy, as this is critical. Once you know the barriers to implementing an evidence-based intervention, you can target those behavioral determinants. Without that alignment, we won't be able to bridge the no-do gap. For example, if clinicians don't know what the treatment guidelines are for depression, then altering your incentive structure isn't going to address the primary issue to implementation practice. You'll need strategies that target knowledge of clinicians. Lastly, you need to consider your implementation context and tailor the mode of delivery to ensure fit. In this lecture, we established that, while imperfect, having a shared language for naming and defining implementation strategies has many benefits. It can help us more readily compare findings within researchers working in different settings, with frameworks such as those provided by Proctor, helping us to specify implementation strategies in a manner that allows others to replicate our work. Finally, we should always ensure that the strategies we select align with barriers to implementation for our evidence-based practice, which can then be tailored to fit your implementation setting. This alignment is key and ensures that our efforts to enhance adoption, implementation, and sustainment of evidence-based interventions are responsive to those factors that hint implementation.